Okay, welcome to the Wellness Journey. We're located now in Poway, California, with the founder of the Primal Reflex release technique, John Iams. We have the magnificent opportunity to speak with him directly about the foundation of this work, who it's meant for, what it's all about. So we're going to launch right in. How are you doing today, John?
Good, thank you.
Excellent. So thank you for meeting with us.
Mm-hmm.
And when it comes to defining the work, we'll just go ahead and jump right in. What exactly is the PRRT technique?
Yep. PRRT is PRRT, are the initials we use when we speak about it. It's a Primal Reflex release technique. And what it really means is that we really are wired with reflexes throughout our entire body. Our entire nervous system has reflexes at every level of our body that control our functions. And so the ones that I'm most interested in are the most primal ones that also influence pain. They influence pain and stiffness and aching and tension and tightness and all the things that people typically complain about. Reflexes are influencing how people feel, how they move, and also influence how they respond to treatment. So that's the basis to the work, and even though it seems unusual, it sounds strange, the analogy of the reflexes and how important they are to reboot them is if you have a computer and your computer gets hung up and you can't get it to work right, you have to reboot it. And essentially we're doing the same thing with PRRT. We're rebooting reflexes that are causing pain, limiting motion, and influencing people's symptoms, not unlike you could reboot your computer when it gets hung up.
Okay, and how exactly did you discover this process?
Well, I have a 2,500 square foot library attached to my home, which Simone has just seen for the first time, so she now has witnessed it. And it may be the largest private medical library in the world from anyone. I've never seen anyone have anything that compares to that. But in the library, about 25 years ago, I had this book, which you can tell is very dated. It looks about the same as it did 25 years ago, by Sir Charles Sherrington, called The Integrative Action of the Nervous System. Now, even in all my seminars, I've never had anybody tell me that they had a copy of this book, and virtually no one had ever even seen or known of the existence of this book. So one day I happened to look at it and pull it off the shelf and started reading through it, and I noticed that Sherrington was talking about reflexes, but in animals. So he was doing research on animals and looking at how reflexes influenced their movement patterns. Now again, you must remember that this was published in 1901, and in those days animal research was quite common. Today, of course, we try not to use animals for research, but in fact that was the basis to the work. Was I saw that reflexes were something that needed to be looked at in a way that no one else was looking at. And so I began to use Sherrington's concepts in treatment, and the results were nearly magical.
That's quite a leap from the book to techniques. Can you elaborate a little bit more on that bridge?
Here's an example of what may help. I'm sure you are all familiar with a reflex hammer. If you've been to a doctor and you've had a physical, a doctor will typically tap several places, usually here and on your knee, and your knee will jerk, and they're looking at reflexes. And they're looking at the same thing we're looking at, but they're looking at them from diagnostic standpoint. We're looking at them from a treatment standpoint. Now, Sherrington never mentioned the use of a reflex hammer, but he did talk about how powerful reflexes were and how fast they were. In fact, reflexes have been clocked at 325 miles an hour. That's how fast, when a reflex is elicited, it actually is that fast. And so I was at that time following the work of Dr. Janet Travell, who was President Kennedy's physician in the White House. She lived in a home near his place of residence there in Washington, D.C., and he had chronic back pain from his PT boat accident. And so she had developed approaches for treating musculoskeletal pain that I had been using, and they were effective, but sometimes they were painful, and sometimes they didn't work. Sometimes people would have trigger points, which would be a knot that they would have in a muscle, and if you push, they would say that hurts, or they would pull away. And oftentimes before PRRT, I would have to have a physician inject them with a local anesthetic to try to knock out that trigger point. But what I found was, when I started playing with the idea of eliciting reflexes, that I could actually achieve the same result without the injection in almost every case, and dramatically even on the first visit. And that's what really got me convinced that I was onto something, because the first visit, for most people in pain, they don't walk out substantially better no matter who they go to or what's done. But with PRRT, quite often, they're 50% or greater improved, sometimes 75%, and at least in my practice here in Poway, when I see private patients, I usually only have to see people once or twice, seldom more than 2 or 3 times, and they're done. Or I tell them what they need to do to look further into what their problem is at that point.
Well, thank you. In terms of clarifying reflexes, that's helpful. But who, in fact, is this work meant for? Who will benefit from treatment?
The treatment is beneficial to anyone who has muscle joint pain, muscle, tendon, joint, ligament pain, who may be looking for an answer very quickly to see whether something conservatively, which means non-surgically, non-injection, non-medicated, meaning something that could be done that could make an immediate difference for them. We also have approaches that we can teach patients to reinforce what we've done, so that there are maneuvers that they can practice at home to benefit between sessions if they need more than 1 or 2 sessions. So anyone with pain, particularly if it's muscle, joint, tendon, ligament pain, not as much if it's nerve pain, although sometimes it can be helpful, those are the people who benefit most.
Where do you see the work going in terms of the future? Are you seeing other additional practitioners doing this kind of work?
Yeah, I mean, I think as the work becomes better known, I mean, we're in 16 countries now with practitioners who are trained at least with a home study course. As people begin to discover this, people who treat pain, whether they're chiropractors or physical therapists or osteopaths or massage therapists, I mean, whoever they are, physiotherapists is what they're called in other parts of the world, they will recognize, I believe, that this is a missing piece. It's probably, in my mind, the biggest missing piece in the entire puzzle of pain, and it deserves to be integrated into what they're already doing, particularly on the first visit, to see how much dramatic change can occur for someone, and that really encourages people to come for a second session because they know already that they're in the right place for treatment.
Are you continuing to discover new techniques and new ways to utilize this work?
Yeah. The work continues to evolve. There's faster and faster ways to get results. We've added concepts of other tissues like fascia. We have an instantaneous fascial release. There's all kinds of other works out there for treating fascia, myofascial pain syndromes, but ours is instantaneous, and it's faster than anything else I've ever seen. We also have a way of influencing lymphatics. So I continue to look at other systems that we can actually help people to achieve faster results. And we even include discussions about nutrition, how important nutrition is, both what you take and even foods to avoid, like nightshade plant-based foods. So there's an emphasis on really trying to take a very holistic approach to the influence of someone's symptoms and trying to have them participate as much as possible in understanding what they need to do at home in between visits. The other thing that's important that I'll mention is, if PRRT is someone's answer, it must work within a couple of sessions. It's not something that's 3 times a week for 3 or 4 or 6 weeks. I mean, I can't believe how today in this world people are still going to practitioners of all different trainings for weeks and weeks, sometimes months of treatment, and sometimes with little or no change, somewhat on the expectation that someday something's going to happen and all of a sudden they're going to get better. And it makes no sense to me. Also, financially, it's really hurting our healthcare system. So, I mean, with PRRT, we have to see changes as the first few sessions are done. And if people don't see changes in the first few sessions and they're doing their part with what they've been instructed to do, then PRRT may not be their answer, at least all by itself.
Does this technique blend well with other techniques?
Yeah, it's amazing how it can blend, and so people can simultaneously be getting other forms of treatment. They could be getting fascial work, they could be getting massage. They sometimes continue to go for chiropractic adjustments. So yeah, it very naturally does seem to blend with other approaches, and it thereby augments and can substantially improve the results that they're getting, even if they're continuing to go to see a different practitioner.
In terms of the future, do you have an idea of where it's going in terms of being integrated into a professional curriculum so that other practitioners will know about it?
Well, we're now, as of the last couple of years, we're now on PubMed. PubMed is considered to be evidence-based research. That's the criteria nowadays for legitimacy in someone's approach to treatment. And so, from that standpoint, we're in PubMed, and we have several articles that are published, and there are more that are coming. So I see that being much more a part of our work, and also I see that PRRT will become more integrated into the physical therapy schools, eventually into other disciplines, hopefully osteopathy and chiropractic and massage. So evidence-based was critical for us, and we're now there, and we're having more research being done all the time. So I think the focus on the research background of PRRT will become more prevalent, and I think will become better known and better respected just as time goes on because of that.
Okay, sounds good. Anything else you would like to see happen with this?
Well, let me mention who the work is not appropriate for, because
Okay.
that was one thing that you and I were talking about that I probably should mention. I think the work is not appropriate for someone who, first of all, expects magic to happen on one visit. So, I mean, as important as his work is, and as powerful as it is, and how as effective as it is, it's not something that people get relief of pain all the time on one visit. It's not that. Some people do, but that's not what they should expect. On the other side of the equation is it's not appropriate in my mind for people who have chronic health issues that are underlying potentially their complaints of pain. I'll give you an example. We don't talk about often enough some of these conditions, and I'll just mention some, but I won't list all of them. So one is mold toxicity. We don't talk about mold very often, but people, amazingly, how often people's homes have mold issues. And they just don't think that this could be something that could affect their health, but it can. Lyme disease, where someone has a tick that they were bit by a tick, and they didn't think anything of it at the time, but Lyme disease can actually show up as fibromyalgia type symptoms, which means people can have total body complaints along with energy loss. So there are a number of conditions that people can have I won't go through a list of them, but for those people, PRRT may not be appropriate and it may not make a change. So what we're really looking at then for appropriateness is people who have muscle, joint, tendon, ligament, fascial-based pain, and it's thought, at least at the time that they come, that that's the source of their symptoms, and whether that's arthritic or not, whether that's so-called bone spurs, whether it's just partial tear of a tendon, whatever they think it may be, those are the people who tend to do best with PRRT. And so I wanted to share that because I think it's important to know that there are cases of conditions, like I mentioned, with, let's say, Lyme disease, that PRRT is not going to be that person's answer. Same thing with mold, toxicity. So that's what keeps us from saying that everyone is going to be helped by PRRT, because we surely don't say that.
Okay. When doing a PRRT exam, is it necessary to be on a table, lying flat, either face up or face down, or can it be done in a chair?
It's possible to examine portions of the body in a chair, if we're talking about a massage chair,
Mm-hmm.
but you don't have access to all of the body.
Mm.
And so you could get an assessment of the posterior or the back portion of the body, but you would lose some ability to access and assess the front side of the body. It really depends on where the person's problem is coming from. If they're there for back pain, it would be no problem to examine them, on a chair.
Yeah.
But if they're coming because they're having pain in their chest and they're lying on a table, a chair, I should say, and this is not accessible, then it would be hard to examine them for their ribs and their breastbone and other tissues that we may need to examine.
Right. Well, there are people that are comfortable in some positions and not others, so that's where the question was coming from.
Mm-hmm.
In terms of the overall picture, if you think back 25 years ago, would you have imagined where you're at today?
No, because, with it all starting here and having this book be outdated,
Mm-hmm.
And having nobody having heard of Sherrington's work, it almost defies logic and the possibility of PRRT evolving from this to where it is today doesn't seem possible,
Mm-hmm.
but yet it has.
Yes, it has. And research is going to be carried on. Are there areas of research that you're hoping will take off? Anything specific with regard to that?
Yeah, I'm glad you asked that, because the feeling I have now is that what we need to have is a system of health care that determines whether people are going to respond or not, and not have a 3 times a week for 3 to 4 to 6 or more weeks of treatment before we decide they aren't appropriate. So the answer to your question is, I think a model for the future, if someone isn't sure about whether they might benefit from treatment, would be if they were seen once a week for 3 or 4 weeks. They could even be seen 3 times a month, every 10 days. So there's a little more time in between for them to implement the strategies that they're being taught, because we do teach strategies for people to help themselves. There are home exercises that we've developed that are related to PRRT, and then also some of the nutritional recommendations, helping them to learn better about sleeping. All of these things are very important.
Wonderful. Do you see yourself authoring more books to get the information out, either to the public or to practitioners?
Yeah, I'd like to. I'd like to have a book out maybe within a year's time for the general public, not for practitioners to start with, and then eventually, hopefully, something that would be for practitioners,
Mm-hmm.
in that order.
Wonderful. I want to thank you very much for your time and for your incredible work.
You're welcome. Thank you.
Yes.